Good morning, everybody. It's nice to have you here again on this Saturday morning. It's so brave of you to get up to be here at 9 o'clock, but I can assure you it will be worthwhile. Because this morning I'm very pleased to introduce Professor Siebrecht Vanhooren. He's a professor in clinical psychology at the Faculty of Psychology at the KU Leuven, University of Leuven, and he's an expert in existential and experiential psychotherapy. He has also great knowledge about qualitative methodology, and he will tell you something more about all those existential topics that are so intriguing. So, Siebrecht, I'm very happy to have you here. The floor is yours.
Good morning. Can you hear me? Yes. Okay, perfect. I also can hear myself, which is interesting. Thank you for calling us being very brave to be here this morning. And thank you all for being here. I have to say, what I really want to say is thank you. Thank you for having me here, showing up, and thank you for the people who organized this conference for inviting me this morning. Let's start with a little introduction. So maybe self-disclosure statement. So, because I think even when we look at data, quantitative data, who we are, influences what attracts our attention, and how, what kind of article looks interesting or not. So I think everything is a kind of subjective. So I'm from Europe, Belgium and Flanders. For people who care, my pronouns are he and him. And I'm a clinical psychologist, and I'm a person-centered, experiential, focusing oriented. So it means like I'm interested in a lot, actually. And I think that's part of being a Belgian, that we try to integrate things. Like we are used to, we are a country with different cultures. So in Leuven, we kind of developed our own brand of existential psychotherapy, and we call it experiential existential psychotherapy, which is a kind of, for people who are interested, of humanistic, existential humanistic psychotherapy, but humanistic in the sense of humanistic psychology, like Maslow and Rogers, etc. There is another part. I'm part of the progressive Judaism. So I Shabbat Shalom for maybe other people here in the room, and for everyone, Shabbat Shalom. And it causes, of course, a minor crisis for me because I'm working on Shabbat. So there's maybe a little sense of moral injury, but it's very mild until now. It depends what happens during this talk, of course. But I thought, okay, how can I negotiate being here and doing, this is work, like talking about existential stuff. And I thought, let's do it in the spirit of Shabbat, which is a day of abundance and wholeness. And so I gave myself the space to open with very wide existential questions, because I often wonder about those things, right? So I work together also with people who are working from a CBT point of view. And it's interesting, there is a lot of overlap with all kind of psychotherapists, because we are working with people. But maybe one of the differences is this idea that, or the kind of the awareness that we are working not only with the symptoms of people, but with the people, right? And what is life without life? And are people, with what subjects do people come to therapy? With life subjects, because there is nothing else in our life. When we are suffering, we are actually suffering from life, right? Whether it's a broken ankle, or whether it's anxiety attack or anything, it is about life. There is no escape. When we suffer from life, we suffer with life also. Also, when we are concerned about people who are important to us, it is actually always about life. So is there anything else that we are taking care of when we are working with our patients or clients? No, right? So I mean, that's how I see it. Also, feel free to object or to interrupt me or to ask questions, because that's how I like it, to have a little bit of an interaction. and it's more of an adventure then. So, so isn't every human problem a problem of living? Right? It's kind of maybe a rhetorical question, or maybe not. I don't know what you think, right? And what are we taking care of? What are we caring for except for life itself? And it makes me think of Paul Tillich, who makes here a little leap of faith, I think, in front of his books. And Tillich says in his book, The Courage to Be, which is probably widely known also for you, he says that we are primarily and ultimately concerned about our being, right? About our being. And when we feel threatened in our being, there is like a sense of anxiety, existential anxiety and despair when the situation doesn't seem to move, or when we're stuck in this situation for a long time. And another interesting person is probably less known, is Otto Rank. Let me situate Otto Rank a little bit, because I'm going to talk about him today. Otto Rank was one of the people of the inner circle of Sigmund Freud. But Otto Rank was the only philosopher in that first circle with Sigmund Freud. So he was not a psychiatrist, he was a philosopher, and he did psychoanalysis. And they had kind of a fight, which happened between Freud and many people. And because Otto Rank wrote a book, The Trauma of Birth, and actually he was calling attention to the important relationship between mother and child. And for Freud, this was difficult because in his way of thinking, the problem was between the father and the child. So, and then there were probably some father-child issues between Freud and Rank, and that was the end of their friendship. And Rank went to America, and he's actually the forerunner or forebearer of all humanistic existential psychology. So he really inspired Yalom, he really inspired Rollo May, Carl Rogers, etc. So it's very interesting to see those traces. Also the terror management theory, it's really heavily influenced by Otto Rank. So Otto Rank says in one of his books, The Therapy of Will, or Will Therapy, he says all human problems are, at the last resort, problems of the soul, which is a very interesting concept. And I think I wouldn't even quote him that way if I wouldn't be in a kind of a safe space where people think about religion and are kind of open for it, right? But what is the soul for Otto Rank, who is Jewish? The soul is not like something that is not embodied. It's kind of an embodied soul. There is a relationship with breathing, like with the core of life, with being alive, with being physically also alive. So it's a little bit different. But he talks, in fact, about when we suffer from our soul, or when we have soul pain or problems of the soul, he talks also about the human condition and all our existential problems that we face during our life, all our existential challenges. And actually his whole therapy is about working with existential challenges, which was really new at that time and still very inspirational. I really would like to encourage you to read Otto Rank and maybe a little book of Robert Kramer of 2019 on the birth of relationship therapy. And he looks how Otto Rank influenced Carl Rogers. Really, really beautiful, small book. Anyway. So this is kind of my Shabbat kind of entrance into this talk. And now I think we are getting, we will gear to a different direction. So if this would be the case, that people who come to us, who is actually working in healthcare or pastoral care or psychotherapy, can you raise your hands? So some people, so yeah, please, if you don't agree, let me know. But I think if this is the case, that we are actually working with the existence of people in one way or another, why is it not common to address those existential themes in our healthcare system? What happens? Like how is this possible that we seem to be not eager to talk about those themes in counseling and therapy and healthcare? Of course, you are doing this because you're a special group. But many of us don't, like doctors hesitate. There is really hesitance to talk about existential themes. So another question we could ask ourselves is it really necessary to talk about existential issues in therapy or in counseling? So we'll think about that during the next hour. What keeps us from not doing this? And what could be of help for people who want to address existential themes with their patients? Is that okay? Is this interesting enough for you? Okay, good. I mean, if you would say no, then I would have a big problem, of course. So thank you so much. Good. So let's have a look. Do clients actually want to address existential matters, right? So, so we could say, of course, in a way, everything is existential because you're alive. But let's talk a little bit about those explicit existential themes, right? Those themes of life and death, or like loneliness, like existential loneliness we talked about yesterday, or moral injury, or other more typical existential topics. For me, it was very helpful to read a book of Alice Houtze-Kunz, who is a Daseinsanalyst, and she wrote a very brilliant book, Daseinsanalysis, in 2014, and she makes the difference between the ontic layer and ontological layer of our problems as human beings. And very often, people, you know, when you get up in the morning and you deliberate whether you would have coffee or tea, you know, that's clearly not an existential. It could be very existential. It might be an existential layer there, because you could start to think about, like, is this fair trade coffee or not? And then what happens with our planet, and, you know, the limitations of the planet, and this and that. And that's more like an ontological layer. But probably this morning, you just had your coffee or your tea, right? So we just do things. This is like how we deal with life in an ontic way. But then, of course, there are the questions of being. So today we'll focus on those on that ontological layer more. So do clients want to address the ontological layer of their concerns? So I had a look in the literature. Because, of course, I would say immediately yes, and because I'm an existential therapist, but that's not fair. Let's really look at what clients have to say. So I found a kind of old but interesting article of Morgan and Winterroth. I worked for many years in a prison system, in a high security prison in Bruges, in Belgium. So it was not hard for me to find that article. I read it before and I remembered it. And they say that therapists systematically underestimate the client's needs or wishes to talk about existential matters. And they refer actually to two studies. It's based on a questionnaire of Erwin Jalom, who wrote also a lot about group therapy, as you probably know, and not only about existential matters. So he had like a questionnaire with 60 items about what therapeutic factors would be beneficial in group therapy. And let's have a look. So there was like a very old study of Morgan Farrell and colleagues, and they interviewed 59 therapists, group therapists in prison and prison systems, and they let them rate the what they want to put time in their group therapy, what seems to be important, what progress would be important with their patients. And as you can see, existential factors are really, really low here. So it's like almost not important at all, right? So there is not a lot of importance. That group therapists think it's not important. They don't spend a lot of time and they don't expect a lot of progress. But then there is another study asking the same question to patients, to offenders in this case, like prisoners who are in group therapy. Older study, you see like the kind of typing, of course. That's and here, offenders in a minority security system, they put like existential awareness in the second, and here maximum security, the third, and here the first, and segregation. These are really people who are like totally confined. So it's interesting to notice the difference, because these were actually the patients who were also in that kind of group therapy. So we really see like a big difference. That's old news, right? Then there is a study of Jessie of 2017, and she did a study with chronic pain patients in Belgium, right? Okay, yeah. And the participants were not really happy with the amount of care or interest they got from their mental health care workers regarding their existential concerns, correct? Yeah. But it was interesting to notice that for the people who were satisfied, there was an association of lower pain intensity and less depressive symptoms and higher life satisfaction. So it seems like, again, like patients experience or actually a bigger wish or need to talk about those existential concerns, but are really not satisfied with the amount of care they get from their healthcare workers. A little bit in the same line, there is a study of Clara Hill, who is a psychodynamic therapist, and she interviewed 212 therapists from different therapeutic approaches. And those therapists estimated that 1/3 of their clients, which is already very high, right, would be searching for meaning in life. So that this is actually an issue in therapy. 1/3, that's 1 of your 3 clients who just come in therapy without actually being really specific about, like they're not looking for pastoral care, they just go in therapy, but 1/3 actually was interested or had like concerns around meaning in life. And we did our own study a couple of years ago in a smaller group, but with clients, and we see that 2/3 of the clients actually expressed that they were searching for meaning at the start of their therapies. It doesn't mean that those therapists worked with that existential need, but we see like it's a higher proportion. So it's like a couple of times that we see that there is like kind of a difference between what therapists or counselors think about existential concerns and what probably clients experience. Of course, this would need to be replicated on a larger scale, right? But this is just maybe a taste of a kind of direction. Are you okay with that? Any questions so far? Saturday morning. Yeah, good. The same, we did 2 master theses on 85 outpatients, cases with a minimum of 15 sessions. Those clients were in person-centered therapy, but most of them didn't know because person-centered therapists usually don't say that it is person-centered therapy. And we could retrace all existential givens of Yalom in the post-session comments of the clients. So the clients wrote after every session what they have been talking about and what was helpful or what was actually disturbing in their session. And we saw that actually we could retrace all of those 4 existential givens during the course of a therapy. Of course, not all in one session, but we could retrace like problems of clients with the limitations of life. And that could be like not being able to have children or a divorce or loss. Also struggling with meaninglessness and a search for meaning and not finding meaning in life, like identity crisis, etc. Also struggling with taking responsibility over their own lives, ownership over your own life. And then existential isolation and connectedness was like really, really high in that population, in that sample. And also the therapeutic relationship was actually part of that experience of this existential given, because we'll see today also that when we actually are in contact with our clients, that the existential themes are not only in the client, but also in our therapeutic relationship, right? It's not an individual thing. How could it be? Good. And last, a very interesting idea. It's not a study of Tom Greening, wrote a small but very inspiring paper in 1992, I should say, about the fact that there are many different ways to react to existential challenges, which is, of course, normal. And he says that there are like 3 big possibilities with a lot of overlap. And he says like people can really be demoralized when they are existentially challenged. On the other hand, people can be like overly optimistic and positive, like everything makes sense in my life, right? Like life is good, like there's always meaning. And then there is like a middle reaction or a middle answer, like to really acknowledge that life is sometimes meaningless, that there are moments of darkness, and there's also moments of actually meaning, like a kind of being able to bear the ambivalence of life. And what we see in the literature, in the newer literature, that is that negative answer towards our existential challenges, the stuckness, right? Being stuck in meaninglessness, or being stuck in our experiences of loss or existential loneliness, that kind of correlates with psychopathology. And there is the idea that maybe those existential concerns could be called transdiagnostic factors, which means that these are factors that could cause or could maintain mental problems in people over different disorders, not depression or not personality disorders, but over different kind of psychopathology. And we have like some overview studies how death anxiety really correlates with all anxiety disorders, from PTSD to OCD to general anxiety. It really highly correlates, and that makes sense because when we are afraid, what are we actually afraid of? We are afraid that our life would stop and that we would really be in a lot of pain. So that's what we are afraid of, right? Yes?
I'm curious which one OCD is connected
with death anxiety. Yeah. And it makes sense because what are you doing with obsessive compulsive disorder? You try to control your environment because you don't feel safe. So there is a felt threat, and actually the OCD tries to control your whole existence. And there's like a high rate of death anxiety because you have the feeling like something really terrible can happen to you any moment. So you're trying to have an impact on that. And that's how and of course, it's really strong. It's very hard to treat OCD because there is that high death anxiety, right? Yes.
Is there any definition of what death anxiety really means? Because there are many different aspects, being afraid of what's coming afterwards, being afraid of suffering, being afraid of losing control.
It is mostly in this, because this article comes from the terror management theory. So it's translated as mortality salience. So the awareness that you're mortal and that you're very highly vulnerable and that your life can end. So this is how it is actually studied. We see also meaninglessness correlates really highly with all types of psychopathology, especially with depression, existential isolation, and also hopelessness, despair, helplessness. And I think that's like the counter experience of freedom, responsibility, making choices. Right? When you feel helpless, there is no choice. Right? There is like no freedom to react. Right? So there's like you cannot move anymore. So it's interesting how we see that those existential topics might be there in the room anyway. So it's just interesting to think about that, and helpful because it's a way also to, as a clinician, to also make that link with those existential topics. But okay, how do counselors and therapists react when their clients start to come with existential concerns? Very often in this way, help, right? Not with you, of course, but with the majority, it seems, of counselors and therapists in the States and here. Okay, How do we know that? Clara Hill did a study with 212 therapists, and most therapists, but really a lot, had the experience that they felt unequipped to actually talk or to deal with the existential concerns of their clients. We are talking about experienced therapists, except for humanistic and existential therapists. Hooray! Okay. Because one of the things they said, because it kind of went inside, and they felt like they were like existentially questioned themselves, because when clients raise those questions, something is happening there. And we see that also in other studies. There's of our Swedish colleagues here. We have seen that, we had a look at those different studies, and it seems that when we talk about mental health workers, or with like in who work with different populations, with young people, with elderly people, with all kind of people, that there are always participants who say that they feel overwhelmed by the existential questions of their patients or clients, and that in some way or another, that it evokes reflection on their own existential themes, which can be very highly challenging, and that they feel sometimes powerless or helpless, and that they sometimes also withdraw from actually the relationship between their clients and themselves. And we talk about existential shattering, and this is a kind of other word for the shattering of our world assumptions. So something is really threatening there when we talk about or when clients bring existential concerns. So it seems like when you are talking about existential concerns, and there is a big help from the from the side of the client, that there is also sometimes a cry for help on the side of the therapist as well. So that's why it's kind of sometimes an SOS situation, right? We just submitted a study of a meta-synthesis of 2 of our own qualitative studies, because we wanted to check how that was for therapists or counselors who are really working explicitly with existential themes. One group was a group of 10 counselors and therapists who worked in abortion clinics, but without having existential training, right? So they were like trained in a one was person-centered therapy, another one was systemic therapy, were like all kinds of CBT, etc. And the other study was with humanistic existential therapists. And because they were all working with existential themes, it was really easy for them to kind of identify existential themes in the stories of their clients. So that was like similar, but we saw a difference. And the differences are always more interesting, right? So what could we see that is that existentially trained therapists could identify also existential concerns or existential dynamics in the process of therapy. So there was something that was different. They also could contain ambivalence, their own ambivalent emotions or reactions. So those therapists said that they kind of sometimes felt like powerless, but at the same time, they also felt like a kind of gratefulness because they could share this moment with their clients. Or they said like, yes, it's really intense, but at the same time, I feel like my work is more meaningful, and it makes me think of existential themes, and it helps me make better choices in my own life. And they also said that they experienced a shift from trying to solve the problem and doing something so it would quickly go away, to actually to be more empathic and to be with their clients during their career. So they experienced a kind of a shift in working with existential stuff. So something is happening there. I find it interesting. What do you think? Any thoughts? I see some people nodding. Questions? No? Okay.
I think this might be also a question of age.
Yes, We saw also that,
experience.
yes, we saw also that we have seen that in a new study, but it's not submitted yet, so I didn't put it here in this PowerPoint presentation, but I can talk about it, of course. We compiled a new questionnaire on existential empathy. I will talk about it later. And we saw that therapists and counselors who are older show more existential empathy, or like more at ease with those existential questions of their clients. But it's hard to differentiate between clinical experience and age, of course, because that goes together. But it could be that people who themselves had to go through existential struggles, that we kind of build up a kind of way to be with the existential problems of the other also. So that's totally right. Good. So that brings us to the concept of existential empathy, because I think it's different than ontic empathy. So existential empathy could be the capacity to resonate and empathize with the existential concerns of the client and to communicate this kind of empathy. It's kind of based on how Rogers defines empathy as such. And I think just because we see differences between therapists, that it is something different. Like we saw in our last study, that therapists who are more experienced actually also could contain more those existential feelings of the client and could be more present. Another experience that gave me the inspiration to differentiate between ontic and existential empathy is that we see that almost every year with the people who we train in existential empathy. Also people who are already therapists, who are already person-centered humanistic therapists, who have been like bombarded with empathy training, they still say after the end of the training, like, it's like I've gotten a new vocabulary, new words to communicate my empathy. I feel like I'm more at ease. I can really be there with my patients much more. And it was like something I was actually afraid of before.
Do you have any idea about the inner resources of the therapists that are able to?
Yes, I will come to that. Yeah.
Is there any information or research on support for therapists, supervision,
Yes.
training?
Yes, I'll also come to that in a minute. Thank you. Nice. Yeah. Okay. And if it doesn't satisfy what my answer is, ask the question again. Good. So also Carl Rogers talks about a kind of different kind of empathy. He doesn't call it existential empathy, but he says there is like a kind of a deeper empathy which makes clients feel confirmed in their being. So there is like kind of the ongoing empathy that you try to empathize with what the client is talking about, but there is also like a qualitative jump at a certain point of, and he says it feels like clients feel confirmed as a person, and they experience in this empathy the right to exist as human beings, right? And he says it seems like this kind of empathy seemed to bridge the existential loneliness of the client. It doesn't mean that the client doesn't feel a separate individual anymore, but something seems to happen. Like it's like easier to bear that existential loneliness. And of course, Rogers had a huge influence on the person-centered approach and the person-centered care. So I recognize a lot, Helena, what you were talking about yesterday.
Can you just review one more time the difference between ontic and existential empathy?
Yes, sure. Ontic empathy could be like, for example, that a client comes, and I'm just making fantasy now, and comes and talks about, it's hard to get out of bed this morning, you know, it was a late night last night, but there is that very important conference I'm going to, and I want to go to that keynote, and I hope it will be worth it. but you know, I couldn't, and I stayed in bed, and I feel really rotten. And so as a therapist, you could like empathize with the fact that the client couldn't get out of bed and it feels really rotten. But you also could go, I think, on a deeper level, and this could be something like you really feel disappointed that you couldn't go, and you're like struggling with the wish to make something of your life, and yet something is making you that you're not going. And it might feel, does it feel empty, or how does it feel? Because you know that this client suffered with similar aspects, like clients, you know, doesn't go to work, and there's like a disappointment with her life, for example, or life feels meaninglessness. So you can stay on that ontic level and empathize just with the fact, or actually refer to disappointment with life, for example. This could be an example. Also, Otto Rank is talking about empathy, and he says how empathy has the power to transform the way we relate with existential concerns. And then we are not talking just about empathy in kind of a response, but of course an attitude, like the empathic attitude towards the clients. And he says, like, in that moment of meeting, that moment of empathic meeting, you can really experience the existential concern. Like in that example, if I'm just talking about getting out of bed, I don't open the door to experience that feeling of meaninglessness or pointlessness of that life of that person, right? But there is also the experience of the existential meeting. Like you can you kind of meet each other in that existential concern, and I will give an example of that. There is an old case of Miss Mann. It's really a lovely transcript of Rogers of 1955. And I could have picked things that are less old, but I just love it so much. It's one of my favorite parts of therapy sessions with Rogers. And the client talks about the fact that she thinks she has cancer, but the doctor doesn't know it yet, and the doctor wants to check it, and she goes on and on and on. I won't like go literally through this transcript right now, but that's what she is going through. So she talks and talks and talks, and he wants to do x-rays. And she says at a certain moment, that really frightens me terribly. And the therapist said, And I think it's when I let that truth come to me, maybe it is, and what if it is? And that's what I feel so dreadfully alone. So she talks, and Roger says, you feel like it's really something like that, then you just feel so alone. And there is a silence of 8 seconds. And then she says, and it's really frightening kind of loneliness, because I don't know who could be with you, and it seems rather silence. And Roger says, is this what you're saying? Could anyone be with you in fear or in loneliness like that? The client starts to cry. Just really cut so deep. And then she starts talking again. I don't know what I would feel like if there was somebody around that I could feel sort of as though I did have someone to lean on, in a sense. I don't know whether it would make me feel better or not. I was trying to think, well, so she starts to talk again. But it's just something that you have to grow within yourself, just sort of stand, even just the thought of it. I mean, it will be 2 weeks, I suppose, before they know. Would it help to have someone else around? Or is it just something you have to really be intensely alone in? And that's I just felt that this week so dreadfully, all by myself sort of thing. And Rogers goes further, says, just a feeling as though you're so terribly alone in the universe almost. So this is kind of the experience, I would say, of existential loneliness. Do you agree, Elena? Yes. And whether whether anyone could help, whether it would help if you did have someone to lean on or not, you don't know. I guess probably basically that be a part of it, you would have to do alone. I mean, you just couldn't take anyone else along in some of those feelings. And yet it would be sort of a comfort, I guess, not to be alone. It surely would be nice if you could take someone with you for a good deal of the way into your feelings of aloneness and fear. And then she said, I guess I just have, right? So what Rogers does is actually empathize with that existential loneliness, stays with that existential loneliness, and at the same time, something is happening. There was like an existential meeting between those two people, and something is shifting into her. And this is what I think is existential empathy, right? So they don't go into the cancer, they don't go into what the doctor has to say or not, or who could help her. You know, he also could have made that choice, like who could you call? Who could you text? Of course, this was not possible in 1955. But he stays with that existential concern. And I think that's something that many people don't do, or many therapists don't do, because it evokes a kind of fear maybe, or helplessness, but he's able to do that. And that's why he's just such a genius when it comes to empathy. Good. So we know, I will just look at the clock, that empathy is one of the most studied, the most robust predictive variables in therapy, and it has a robust influence on therapy outcome. And we know it's about creating a safe space, a space of connection to explore difficult issues like we just have seen. What it also does is a kind of emotion regulation. It's a kind of co-regulation. While I'm searching for words as a therapist, I'm kind of regulating my own emotions. And my search for words helps to regulate also the emotions of the clients. So there's like co-regulation, right? So this is one of the things I think of existential empathy. And it also unlocks what my PhD students call an existential space, like you go into a different space, like what Rogers did. He creates kind of a different space in therapy where you actually can talk about those existential concerns. But the problem is, as therapists, that we are also becoming part of that existential space, which can be pretty frightening for us, right? But also interesting. Now, I think empathy and the therapeutic relationship and meaning in life and existential concerns have a lot to do with each other. So we did a kind of a study with 145 outpatients in Belgium. We saw that there was like a statistically significant association between meaning in life and the therapeutic alliance. This means that these are the experiences of the clients, right? So it seems like there is like a kind of correlation between the experience of the relation with their therapists and their experience of meaning in life. And we saw that also in a smaller study with 96 patients in Belgium, that meaning in life even seems to mediate between the therapeutic alliance and the therapy outcome. But this was only in the 5th session. And these are only starting studies around existential concerns, meaning in life, and therapy. So we seem like it's kind of part of the therapeutic process. Yes, okay, yeah. But good. What is the problem? Indeed, that therapists can feel overwhelmed, because I think with existential empathy, you're not just talking about the situation of the client anymore. It's not about that specific life narrative of the client, but when we talk about existential concerns, we are like fully immersed, because we are also talking about, you cannot talk about death almost without reflecting on your own death, or meaninglessness without experiencing also some kind of meaninglessness, because we know that empathy also depends on a kind of embodied reenactment. We have those mirror neurons, and we kind of reenact what actually the client is experiencing. But when you're talking about something that is not different from you, then it's really hard also to make the distinction between yourself and the client. Because we know that the difference between me and the other, when I empathize and when I actually try to understand the other, and because we kind of can physically feel it, what the other is actually going through, it is only matter of intensity that I know it is the client who is experiencing this or me. So when we are coming on existential concerns, when it's not clear anymore that it's not only about the client, but it's also about me, it gets tricky, you know? There is like the distinction between me and the other becomes really thin. I think that makes the difference between ontic empathy and existential empathy. Another example, and that's why I think therapists react like that. We did a little study with 26 therapists. We showed them a video of a client who was really suffering from meaninglessness. And we saw, and these were trained therapists, by the way, and we saw that the majority, like 60%, wrote down that they felt like they were like taking distance from the clients, because we come on a common ground, meaninglessness, meaning in life. So it's getting really close. I think that's a lot. I think that's really surprising for trained therapists. So there's clearly something happening. So I think that's also something I experienced actually last week, but also a trained therapist. He was also a trained existential therapist. And he was also a guy who was interested in doing stuff in nature with their clients. And he had one client who was really suffering from meaninglessness. And every time they talked about it, it was like saying, let's do something. Let's go outside in the woods and let's do some action therapy. And it was his way of actually not dealing with what the client was suffering for. So I sent him back into the therapy room and said, just sit it out, right? And stay there with your client instead of both running away from it. Okay. I see my time is almost done. So actually, let's go a little further. I think I will post the PowerPoint so you can read it by yourself. I think it's true what Roger says in 51 in his book, Client-Centered Therapy, that therapy is actually about the essence of life. And actually the way to understand therapy is also looking through that lens. What can be helpful? I think what we see, also what we read with Paul Tillich, he says, if you actually want to face non-being, you really need to be grounded in being. You really need to actually connect, because connection is kind of a way to stay connected with life as such, right? So we really try to help our trainees to get to be better grounded in themselves, to think about existential themes, because that could be helpful, right? To also think about their meaning in life. And Roger says, we need to find our way back home when we dwell in the world of the other person. He says we need to be able to return to our own world. So what we are trying to do is like help people on a cognitive level to be able to name the existential themes in the stories of their clients. That's one thing. But also for them to explore their own existential issues. It's a kind of, how do you call that in behavioral terms? Flooding, it's not flooding, but it's exposure, right? To expose yourself to your own existential themes. To experience that connection in your training, what also seems to help is focusing, which is a kind of connecting to yourself, to your body. It's also a way of grounding. And we found that in a recent study that focusing and feeling connected to your inner experiences actually is associated with more meaning in life, more life satisfaction, less existential anxiety and distress. So these are just little things. I think there are many ways actually to help therapists ground and to be aware of it and to stay connected with something while they are actually in that existential space with their clients. I think that will be it for now. Okay, thank you so much.